Welcome back to another episode of Out of the Blank Podcast. Russell, it is a pleasure to have you back on the show. Do you mind reintroducing yourself for like the third time?
I will, Robbie. It's great to sorry to talk over you. It's great to be back. My name is Russ Ramsay. I'm a psychologist, and my specialty is the assessment and psychosocial treatment of adults ADHD.
Now, when we talk about medications for ADHD, obviously everyone knows about the prescription drugs and the various forms that it comes in when it comes to treating with ADHD, but maybe you can describe more about what the culture of ADHD medication is, such as like things that we use now compared to how there's kind of been a different look or looking into of alternative forms of treatment for ADHD.
Well, based on the current um, science, and it's pretty well established, especially the stimulant medications, the FDA approved medications for ADHD. The stimulants have the best track record, both safety and effectiveness. There are many very good non-stimulant options for people who can't tolerate the stimulants, or they just happen to work better. Every brain's different. Um, a massive review several years ago said for children, and I'm a psychologist, I can't prescribe. These are not medical recommendations. This is just the results of research. That the methylphenidate or Ritalin based medications seem to be the best starting point for children and teens. And the amphetamine based Adderall, probably the most widely known, seems to be the best starting point for adults with ADHD, but they're not the only options. And sometimes a different molecule works different for somebody else. I like what how some colleagues frame treatment options. Um, Medications would be considered a broadband treatment, meaning they generally target the classic symptoms of ADHD: attention, reducing distractibility, reducing the physical and mental restlessness, not numbing anybody. But what I've heard people describe when it's working well for them, the medications buy me time. I noticed a distraction, or what one gentleman described. He'd be driving his minivan, and the seatbelt for the empty passenger seat would be banging against the door. He said, I would notice it, but not get as upset by it. Whereas before it would have been distracting for him. And they're a broadband treatment because, with the platform of such symptom improvement, for many people, it's like prescription eyeglasses. Like what people say with their prescription eyeglasses, yeah, now I'm reading a lot because I don't have to work so hard to read, with the benefits for reduced distractibility, um, increased time, say, with reading or being able to work on homework or around the house projects. They say, with that platform, I am doing better in these broad domains from the improved symptoms. Now, pivoting there a second, again, I'm a psychologist. I do not prescribe medications, but I'm certainly not anti-medication working in this field. What we will see, even with effective medication treatment, some of the early studies of cognitive behavioral therapy, a psychosocial approach for ADHD, that is my approach. Some of the early studies, I'm thinking specifically about Steve Safran. At the time he was at Harvard, now he's at the University of Miami. They would the first studies were looking at individuals on stable doses of medication for ADHD, but they had ongoing residual symptoms. It wasn't getting everything, and no medication is perfect, but there were still functional issues related to time management, other stuff, where then adding in the cognitive behavioral therapy focused on those matters seemed to, as Steve would say, pick up where the medications left off. Now, cognitive behavioral therapy, ADHD coaching, academic support, tutoring, other non-medical approaches for ADHD, they would be in the domain, whereas medications are broadband, treat symptoms and get these broad benefits. The narrowband treatments target a very specific domain of functioning. Now, even though we call them narrow, it doesn't mean that the positive effects themselves can't be broad. But like I will say about cognitive behavioral therapy, And even out some outcome studies like Dr. Safran's, our studies, Mary Salanto's, especially the early days, we would use like ADHD symptom counts, and people would endorse attention getting better and some of these other things. But we weren't really sitting there saying, okay, look at my nose for 10 seconds, take a break. Now see if you can last for 20 seconds before we finish the session. No, we're focusing on the time management, the organization, relationships, getting started on things in a more timely manner, the negative thinking, the emotional effects of ADHD. So these could be pretty broad. So even though somebody might come to us for help because they're falling behind at work, well, the skill benefits at work can also carry over into making sure you keep up with your exercise plan or other things. So that's why very often the combination of medications with, in my case, cognitive behavioral therapy or some of these other non-medical treatments for ADHD works the best for most people. And in some cases, the narrowband treatments, the CBT, the adult ADHD coaching, for some people, they just don't respond to the medications for ADHD. They can't tolerate the side effects. Maybe there's a medical or cardiac condition that obviates their use, or women who are pregnant or breastfeeding may choose not to, or people just choose not to be on medications. They can take on the non-medication treatments solo, if you will.
Can I ask, when people are looking into these alternative treatments for ADHD, how much of it is for themselves and how much of it is because the perceived, I guess, people around them? There's a lot that comes with ADHD, which obviously is personality trait issues. And I've heard this kind of spoken to and from other people's experiences of when they got on ADHD medication. They said people would just be like, "Is there something wrong? Like, are you okay? Is everything? Where's the guy I knew yesterday?" And it was like, well, that person yesterday was annoying, and that's why I was getting this to treat it. So it leaves them in this position of like, what do I do? Do they want me to talk too much or talk too less?
Right. No, it's a great question. Um, and I'm just gonna, there's probably a quibble with the detail, and it's just a word use. And but this is presumably why you're having me on. Um, Technically, alternative treatment is used to refer to an equally viable treatment. So sometimes, that's used for complementary and alternative medicine thing. I won't even put something out there, but let's just say something um, experimental, or you hear somebody doing, it's not an alternative to say cognitive behavioral therapy or the medications, but very often what we're talking about is complementary. It can be used alongside with, looking for the other things. So like cognitive behavioral therapy can complement medications and vice versa. But what you described there, people being taking prescribed medications, and they describe, hey, I feel different on them, or people say I'm different. Um, and sometimes that's exactly what you're looking for. Hey, you've been on time. You're not misplacing your car keys. Yeah, what are you doing different? Um, but there can be that, hey, where's the jovial person, the jokey person, the whatever it may be. And you're right, some people can feel, stuck in that because in one setting, work or school, hey, this is working really well. In another personal life, hey, you don't seem yourself, or this is not the person I typically hang out with. So working with a lot of people, and again, I don't prescribe, but they're on medication, so I'm hearing maybe more frequent reports on what's going on, and sometimes um, dealing with side effects, where I encourage them to speak with their provider, but also some of the successes. Uh, Generally, and it's a biased sample because it's my clinical experience, but people will say it's generally a net positive. But I would encourage people to speak with their providers to say maybe there's a dosing issue. If it's too much of a, for lack of a better phrase, a good thing, yeah, I'm able to focus, but I'm having a hard time shifting out of the focus to do other things I want to do. There can be other things that's not exactly speaking to the personality style side, where it can be I'm having a harder time getting to sleep, and it could be the timing of the dose or things like that. So there's a lot of things that, as part of the ongoing tweaking, including over time, maybe there's a certain 10 milligrams, 20 milligrams of whatever is being prescribed, where after a while there's habituation, or different circumstances where an up or down prescription is called for, including the side effects of the medications on personality. Now, there's a question about whether the person's making the change because of feedback they're getting, but very often the individual would probably bring it up first. But sometimes, or even the decision to be on medications, it can come from other people. Not that that's necessarily a bad thing, because getting feedback on things or feedback from work or in personal life, and sometimes even the individual goes, yeah, here are some behaviors that I'm not happy with, and I'm trying these other things, but maybe something else is necessary to be on track the way I want to be on track. I mean, one area, it's not the only thing, but working with a lot of college students over the years is being able to focus on and comprehend and retain reading material. And it doesn't mean somebody's going to read like Hamlet in one sitting or anything like that and be able to memorize the whole thing. But generally, just people saying, yeah, I was able to keep my eye on the page longer, get what I was reading. And usually, what people are looking for with, we're talking about medication specifically, but also treatments in general, including managing your day and not procrastinating as much, just looking for reasonable cause and effect. If I work on this for an hour, if I spend an hour reading that, I want to feel I've made some progress on it, that it led to something, and that I can build on, and I can be on time with things, finish the class. If I show up and do the work, I want to know I'm going to, it's I'm going to get some output commensurate with the time I'm putting in.
Now, just to clarify here, but cognitive behavioral therapy is not using a device to be able to put someone in a state where they can maybe tone down their ADHD symptoms. It's more about just management and finding skills and strategies to better incorporate other factors that they might feel like they're neglecting on in their personal lives.
Correct, correct. You know what? And so it is, and just like ADHD coaching is the same thing, and I would imagine tutoring and academic accommodations, even though some academic accommodations or what learning centers have might be, and we have them all now on our phones and our word processing. When I started in the field, and I get no money from this company, but Dragon Naturally Speaking, the voice to text software was something else that you had to buy and download. But now we have these features in our we have access to these features. But one of the complementary interventions that is neurofeedback training, and this has been like one of the discussions over time. And reading a lot of the analyses of what works and what doesn't. Neurofeedback is still, at least my reading of the most recent literature and the reviews, it's in that in between state. It's not where people are saying we can definitively say this is a recommended treatment for ADHD. But on the other hand, it's not getting rejected out of hand, where it's like there's here and there some studies are showing positive effects, but maybe not, no different than placebo, or there's mixed results here and there. And some people, and I'm not going to tell anybody who says they have positive results, no, you're not getting positive results. But it's one of those that has been out there for a long time. It does come from more general biofeedback, which could be something that keeps track of your pulse or your breathing rate, so you can get feedback and then slow it down and do relaxation strategies. So it comes from what's an agreed upon useful approach, but it's looking at brainwave profiles as measured by scalp sensors. Now I know there's other cognitive training, sort of brain training games, which again, I'm forgetting the company that had the class action lawsuit, from overselling the benefits of these games. I'll probably think about it later. Middle-aged working memory. But it was several years ago, probably more than a decade ago. But and what many people say, like with the brain training games, it is like exercise. The more you do, the better you do. But it takes that maintenance. And one of the questions with these and other computerized trainings for ADHD, there was the working memory training years ago, is, does it generalize to the important areas of life? You might do better on the actual brain game, like the example I use, and again, I get no money from them, but the old Wii system. I was a champion Wii tennis player, but does that translate out onto the physical court, if you will? Now that's an extreme example. We're not going for that, but does the better working memory training translate into doing better in math and reading comprehension and things like that? The real world things that we care about.
Now, how can cognitive behavioral therapy help people out of the professional setting more into the personal setting when we talk about dealing with relationships and dealing with friendships, amongst other individuals when it comes to anxieties and other types of emotional factors that are really hard to kind of narrow down? And I wouldn't say paranoia is one of them, but I definitely think that after a while, people start to get a perceived idea of who they are based on their life experience, especially if they were unmedicated with ADHD. And that becomes a bit of a problem because then they start feeling like, oh, they're doing really good today. Then the next day they just feel like they're worthless. And it's like there needs to be I don't really know any skills or mind skills that would be able to be set in your head. Like I could think about budgeting and doing time stuff, but even then that's a problem for me because if I'm thinking about ways of separating, let's say 5 minutes to plan some things ahead, 5 minutes to do this, 5 minutes to do that, well, that's 15 minutes gone out of my day. Now I'm really, I could have been working on this project or this project. And to be honest, that work doesn't get done for that project. I think I'll set out to do it. Now I'll be on my phone for 15 minutes of that 15 I was supposed to be using to work on the project.
Right. Now, that's a great question. Well, that's part of the personalization of treatment. So there are manuals out there, and even um, sometimes people say, well, it's cookbook. It's the same for well, no. The thing about the manuals, like we never had a randomized controlled study of our approach, but like I know Steve Safran, I mentioned Mary Salanto, many others, Susan Young in the UK, Alexander Phillips, and to be able to do funded research, they're not going to get funding to say, hey, do therapy for 2 years with each person and we'll come back. It's usually more time limited. And so they have to produce session by session manuals. Session one, what are you going to do? Session two, all the way to 12 or 14, whatever it is. So in that way, it is very structured. And it's also structured in terms of who gets included in the study. Uh, Generally, for lack of a better phrase, more straightforward cases of ADHD without depression or anxiety. That way we know this is targeting the ADHD. So with that being said, every one of those people who've and teams that have produced manuals, they know in the real world it's going to get personalized. If you have to go over the content for session three a couple of weeks in a row, that is fine, but you're still keeping to something that has generally been found to work. So going back to that question, um, that is part of that is part of the challenge of the implementation of CBT, and I would say it's very implementation focused for the reasons you mentioned. Just tossing planners at people and say, "Hey, go spend time on this." I think some ways I have of framing this discussion, like people would come to me over the years saying, "I know exactly what I need to do, but I just don't do it." So, what good is talking with you about going to do me? How is that going to get me to do it? And my answer to that has been I think I'll use the global we. We're pretty good at helping people understand how they don't do things. Not that you procrastinated again, you were disorganized again, you were on your phone again rather than doing the 5 minute increments. Breaking it down in more granular levels, starting with the CBT. All right, how did you think yourself out of it? Yeah, this was a good plan for 23 hours and 59 minutes, but now that it's this morning, no, I'm not going to do this now because it's not going to work. I don't want to do this, or I'm losing time on other things. The role of emotions. How did your emotions, your felt feelings, anxiety knock you off track? Yeah, this sounded like a good idea, but now that I'm thinking about my day, I'm getting worried whether I'm going to have time for everything. I don't trust the plan. And that can also go back to what you said about the paranoia or the negative thinking that can come from, okay, I know I set out these plans, but I don't follow them, but they don't work out. And I'm putting words on what are really quick mental impulses too. Looking at the behavior. What are your behavior plans? Are they realistic? Is 5 minutes enough? Now it's getting into time management a little bit. Also, what are the distracting behaviors? What are the things that you fall into and maybe overdo because they feel productive? Excuse me. But at the end of the day, you go, why did I spend so much time doing that when I set out to do this? none of this, and I will tell, there's no trade secrets about what works. But in using the CBT approach, and there are specific implementation intention strategies that can be used from the self-regulation literature. They're one of my favorites. The if X, then Y strategy. One of mine that I use in my personal life is if I put air in my bike tires, then I'll go out for a bike ride. Because now, and it is getting down to those granular, what is the smallest step that if I'm doing this step, I've moved from not doing it to doing it, whatever it is. And sometimes with the thinking about tasks when I'm working with somebody, um, defining, all right, what is it that I want to do? And sometimes it's so broad, vague, and non-specific. I would imagine for you, it might be, I've got to edit all my recent podcasts. Well, that's going to be daunting. You're probably going to, oh, how am I going to do that? Because it is daunting. But if it would be, I'm going to go back to the one that is the longest overdue, and I just want to bring it up, relabel it, and listen to it once. That's a more actionable step. There's no guarantee that you'll do it. The relapse rate for not doing things is 100%. Now, this is carrying over a little bit, but for everybody. But we're just trying to change the ratio. And you know what? You mentioned the interpersonal domain too. Um, so one, a lot, working with a lot of adults with ADHD, a lot of ADHD, some of it is private. Like that example I used, nobody what you will know if you edit the podcast later today, if that's your plan or not. But a lot of things are public facing or forward facing in terms of, especially with one's history, things happening in the classroom or not, teachers or parents' looks of frustration, the heavy sigh, the eye roll, the, whatever, that the persons might not have known that they ever did, but that folks with ADHD read those probably accurately to say, oh, I disappointed somebody or whatever. That's I'm putting an overly negative spin on it, thinking about people seeking out help later on who might be overly self-critical and avoidant. There can be, supportive people, teachers, coaches that help people build up the positive elements of their self that can counterbalance some of these difficulties. So like the CBT, the thoughts, feelings, and behaviors and the implementation. And I think on the social domain, um, a way to approach relationships differently. And it also includes how we think about relationships. And one of the common cognitive distortions is mind reading. Oh, I just know what they think about me. I will always say when I'm working with a client, I'm duty bound to say that is probably statistically possible. It may be right. Are there other possibilities? At least one other possibility. And how do you want to approach this relationship? So a lot of the CBT, it usually starts with tasks and behaviors. What do you have to do? What do you want to do? And this could be going to the gym. This could be something for yourself. This could be for your well-being. It could be for other people or for a relationship, but trying to break things down in tasks, defining things in specific actionable steps. All right, you say you want to keep in touch with this friend. What does that mean? What does that look like? And then the third piece of that would be, all right, when are you going to do this? It could be clock time. Okay, at 4 o'clock today, I'm going to take a break and do this. Text my friend. It could be in the flow of your day on my train ride home from work or school, or in the, otherwise that's sort of getting to the flow of your day, or it could be in the flow of your day after I'm done editing the podcast, but before I eat my lunch, I'm going to do this behavior. And part of the task is making sure are these realistic expectations and that's the personalization of treatment.
What model or what audience would you recommend it to based on what have you seen good evidence of it helping? I would think younger adults or maybe kids, this would be a good type of therapy to incorporate just because they have emotional problems. I'm not, damaging that, but I just think it's not as severe as adults' emotional states. And now I think at this point, if you're above mid 20s, you're just like, give me a pill. Like, I don't care what I thought about before, but just try and cure the symptoms so I can get on with a functional life. When you're a kid, there's more options and more avenues to try.
Right. Well, you know what? Generally with kids, the going wisdom is the younger the child, the more behavioral, the higher ratio of behavioral to cognitive interventions, because we're feeling beings before we're thinking beings. Not that kids don't have thoughts and make sense of things and sort of interpret things. Okay, dad says he's not angry, but that's his angry dad voice or whatever.
Takes him an hour to tell a story, I can tell you that much.
Well, that can be part of it, but this is where again, I'm a psychologist, but medications can be helpful with that sort of like sequencing and reining the self awareness. Um, and some of the behavioral strategies, especially parent and teacher training, have been found to be more effective. Helping with the environment. And Amori Mikami, I think she's still at University of British Columbia. She also has a nice classroom setup. It's looking at the culture of the classroom where people are more supportive and whatnot, and including neurodivergence, but just bringing and just focusing on the settings and supports and the personalization, and even little things like if the student is running on, the teacher doing some agreed upon thing, like a little tap on the shoulder or, an arm on the shoulder as a cue, different ways, different workarounds for how do we get these signals of figuring out, okay, I'm in one of these times where I'm overdoing it, sort of like I'm in the midst here now explaining all this stuff. As you get into teens, though, you can incorporate more of the cognitive piece. And actually, Steve Safran and Susan Spritch, they've done some work and have a manual for adolescents with ADHD. Their CBT approach that they started for adults and have studied it in adolescents. So they've had some positive results there. And there are some other programs for middle schoolers, including around driving. Um, and actually the adults, um, many of them are coming in because they say I'm more pessimistic, I'm down on myself, or I can't seem to do anything right, or I'm withdrawing from others. And increasingly in our I'm using the R, still used to be at Penn, or at least the CBT model. I guess it's still ours that I'm modifying. Always paid attention to relationships, but really expanding on that. And another reframe of that is treating relationships as a series of tasks. Okay, this friend, like, what are some good friend behaviors you want to do? I want to be a better friend. All right, how do we define that in actionable terms? I want to text them once a week. I want to accept and be on time for a lunch get together. I mean, it sounds really basic, but the executive function model of ADHD, the attention and hyperactivity and impulsivity and those 18 symptoms, they're not wrong, but they're incomplete. That if we think about the executive function, self-regulation, and follow-through, it's really organizing behavior across time. That's exactly what time management is. That example you used that you wouldn't do, 5 minutes on this, 5 minutes on that, 5 minutes on that. Somebody that might work perfect and they move between the two. You might go, that's too many changes too quick. It's almost like, one of my favorite comedians, Stephen Wright, would say, or one of his one liners was, yeah, a friend of mine and we drove across the country. We split the driving. We switched every half mile. The humor of it being, if you're pulling over and switching, that's going to make the trip so much longer. So your wiring might be, okay, I'm going to spend at least 30 minutes on that. And in that 30 minutes, I'm going to reacquaint myself with the podcast. I'm going to edit, who I'm working with, what I remember from it, notes you have or whatever. And it might just be sitting with it. But even that sitting with it is getting you engaged and more likely maybe to get to the point where you go, okay, let me review it and start editing. Now, I don't edit things, so that's your area of expertise. But sometimes it's like, how do I get engaged with it so that I can get to that part where I go, okay, now I'm in it. So, and people say to me all the time, so these are just tricks to get me to do it? Absolutely, because ADHD tricks you out of doing it.
Can you maybe describe some of your personal experience or what you've learned from CBT involvement therapy on someone who has ADHD, maybe changing a way that you look at ADHD. I think through my many discussions about ADHD, one thing that's changed my mind is I know everyone talks about like all your emotions are kind of like if it goes up to 10, the knob for you goes up to like 15 or goes up to 11. There's that extra level. I would just call it more being hypersensitive, overly sensitive in some areas. It seems like every kind of thing that people complain about with ADHD, whether it's perceiving something, whether it's anxiety, everything that links with emotion just happens to be like an oversensitive factor, whether it's information coming in. You can't read it properly if you're reading it on your own, so you have to take it a couple times to keep refreshing and reading over and over again to finally get the information. Or just music playing. A lot of people can't have it when they're driving and looking for something, but sometimes when there's 15 people in a room talking, people with ADHD really can't function at all. So to me, I've learned that it's more about an oversensitive factor, but I'm curious what you've learned from CBT that might have changed your thinking on ADHD.
Well, you know what? Some of those environmental, if you will, sensory issues, like the large room with too many people, um, that part of what I learned is the the power of context, which is true for all of us. We can set up any situation that is a dumpster fire for our productivity where we go, oh yeah, I want to be able to work here and watch TV while I'm working on something, or yeah, but we know it doesn't work. We can always set up something. So part of it is almost like food sensitivities, cataloging the benefits of cataloging. What situations do you do really well in, and what situations are more problematic? And we may not be able to eliminate the problematic ones, like being in the room with 17 other people, or the really busy family gathering that it's just so hard and draining as well. Peopling is hard work. Um, because you might go out and have a really good time with friends, but you come home and then you go, I'm really glad to have the evening off now because I need to replenish. And it's not necessarily a bad thing, but it's sort of like you're saying the magnitude sometimes. So, but even being, for lack of a better phrase, stuck in that room of 17 people, it's not cheating to say, I'm going to step outside for a little bit or go find a quiet room somewhere or other things to recharge your battery in the context to be able to last longer. Sometimes with even invitations, things like somebody says, let's get together for a nice leisurely dinner, but you know what? After we have the bread, I'm going to be wanting to get up and walk around. So it might be making counter proposals. Tell you what, would you like to get together for a quicker lunch when we're at work? Like what I said, like 45-minute turnaround that they specialize in the business lunch and get people back to the office. Um, Ways so that you can play to your strengths, but also pay attention to, I still want to have a relationship with this friend. Um, Going back to some of the other things he said about emotions. Well, some of the things I've learned, one, like in the cognitive domain, and I think I've shared this before, I've made the contention over the years that one of the central, not the only theme, but probably the central theme that develops for folks with ADHD over time, especially those maybe late identified in adulthood and didn't realize it earlier on, is self-mistrust. I know I can do it. I've done it before. I've done it well before, but I can't 100% trust myself that I'll be able to do it today or tomorrow or precisely when I need to do it in the way I want to do it. So that maddening, yeah, I got this paper done, handed it in on time, and got a really good grade, but I have a shorter paper due this week, and I can't draw confidence that I'm going to even get it done on time, even though it's shorter. And this sometimes like what students would describe or retrospectively in their grades, they said, yeah, my grade was like a scatter plot. It'd be an A one marking period, a C the next marking period, incomplete by the end of the year. And that also gets to the social side where teachers and parents are trying to figure out, what was it? You can do it. You got the A this semester or marking period, but then you ended up taking an incomplete and things like that. So that self mistrust, that I think also influences and is influenced by the emotions, and emotions help us predict, learn from, and predict what's going to happen. And sometimes they come before our thoughts do. And anxiety is a big one because it's the perception of risk, or probably more to the point these days, even just within the field of anxiety, not even focused on ADHD, the intolerance of uncertainty. And for my money, ADHD is an uncertainty generator. And that's why I think there's such a connection between ADHD and anxiety, and even some of the worries to a point you were mentioning before. Sometimes it's not classic anxiety, it's not a worry, but it can be the overwhelm feeling of being unable to keep up with everything, or looking at things that, and this gets at the cognitive too. I see other people who are their parents with 5 children. They both work, and these people seem busier than I am, able to get everything done. And I'm looking at these 5 things and I'm feeling overwhelmed by it. Um, and it's not necessarily, like you said, the spinal tap 11 button or 15 button, if you will, but it can be the fact that it lingers and is heavy and influences the day and leads to people falling even further behind. I mean, it can be really intense, sometimes short, sharp, and quick, and it can be intense and go up quick. And this is sometimes with frustration and anger. But then later on, people go, it goes away pretty quick. And I don't know why I got that upset, but it's like this emotional hijack in a way in the moment, which can happen. But then if you say the wrong thing, or you,
Like a Tourette outburst, but you just have some type of physical reaction with it.
yeah, yeah. And but also a verbal reaction if you say the wrong thing out of the spike in anger and things like that. That's where the residual, that somebody goes, "Oh yeah, I really didn't mean it," but yeah, the other person has, takes offense to it. But the changing a relationship with emotions and that ability to tolerate discomfort, especially at the lower ranges, like thinking about getting started on a task. And I've probably shared this before, but we call it the UG feeling. It's like, I know I do it. I know I'm going to use you again. I've edited these podcasts before, but I don't feel like facing this one. And it could be negative thoughts, or it could just be, no, this is going to be tough. It's going to be tedious. And some of that might be accurate, but this also goes down to when we're making the plans for ourselves. All right, rather than expecting to edit the whole thing, is there a section you can do and maybe get to a benchmark that today feels more reasonable that gets you started? And if you stop there, that's fine. But if you get started and then say, okay, now I'm on a roll, okay, keep going if you have the buffer time in there. So that sort of gets at the behavioral planning and the engagement with the task. And see, these things all work together in a way, in a nested way, because that engagement can also be the exposure for the discomfort at a lower end. I'm going to invest this level of UG to even work on this for 15 minutes. And if all I do is 15 minutes and I stop, I didn't procrastinate. And this goes back to that if X, then Y implementation statement. Okay, if I can log into that previously recorded podcast and set it up, however you do that, then I can work on it for those 15 minutes. And building in on the social element, I've described the main role, the main task in CBT, and probably the main lesson learned is treating relationships as, these roles, responsibilities, duties that we may have, including being a good friend with our relationships where we get a sense of belonging, and breaking it down into what are actionable steps I can do, including, and it's not all one sided. Oh, you've got to make up with everybody else that you annoyed or let down or things like that. It's also wielding your influence and social capital to pursue the types of relationships you want to have. If you're contributing, you can have expectations for, what do I expect from the other person, including calling it out or recognizing when, like, what, this person really, I'm always the one helping them out and they're not there when I need them. If there's an imbalance that doesn't work in your, not that we're looking for manipulating people where it works out only in your favor. No, but maybe you're getting manipulated by somebody else, or it's not the type of relationship you want to have, and being able to set boundaries and say no, and look out for yourself. Because one of the other things, learning about folks with ADHD and relationships, and maybe from some of the sensitivities of frustration, or perceiving letting others down, or sometimes actually letting others down, or being, facing rejection. And there's a whole research on rejection events, including, you know, active rejection. We're not going to include you in the group text anymore. Also, passive rejection. I haven't gotten a message from the group in a while. I wonder what happened. And they just sort of ghost you or whatever the case may be. So it's also looking at your social capital and looking for social situations, work and school situations. I use the example of, you know, proposing the short lunch rather than the long dinner. If you say, hey, yeah, I'm probably better over coffee and lunch than I am a long dinner. So playing to your strengths as a way to build up, you know, positive relationships as well. So relationships are, you know, I think they've gotten a little bit of short shrift, you know, in adult ADHD. And I think, you know, Bill Dodson and the rejection sensitivity, paying attention to that has been helpful. And I think there are ways, you know, the social emotions, you know, feeling rejected or guilt and shame are social emotions. And I can't tell you how many times those emotions are brought up, even in situations where we go, okay, you know, you ran late for lunch, but shame is really an intense negative social emotion that goes beyond that for, I mean, you want to be on time with friends, and it could be other people say, well, you know, I only have 20 more minutes and I have to finish my lunch because I have to get back to the office. There might be, you know, ripple effects of running late, but where shame might be a little, or I would make the case is a really strong emotion to have for something like that. That's a, you know, it may be something the person with ADHD focuses on not doing next time, but that's like one of the specific actionable behaviors within CBT.
Can I ask what your thoughts on are about the unpredictability of ADHD? The reason why I say that is if I asked you, ADHD people are unpredictable. Yeah, you'd say yeah.
Yes.
What about the world being unpredictable?
Hmm.
Why doesn't it jive? That's my thing. Is if ADHD people are unpredictable and life's kind of unpredictable, you'd think there would be a better flow state, but unless it's like magnets where opposites attract and similar things push each other apart, it seems like ADHD people struggle more than neurodivergent or neurotypical people do.
You know what? I think where
From my own experience, I'm just saying, like, I'm very impulsive. I'm very good at the seat of my pants type stuff. But if it's in my terms, if it's something that will mess up the core object in my day, then it really throws me off. Like, for instance, I get all my work complete the first hour I'm there, and then I can just do whatever till I get to go home. But then usually it's like the last 20 or 30 minutes, we get piled a bunch of random crap where I'm like, oh, no, 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 wait, I had everything done. You can't just do this last minute on me. But then at other times, hey, we're going to go to DC and go to a bunch of clubs. I'm like, when? They're like, in an hour. I'm like, well, that's kind of like short notice, isn't it? It's like, you going or not? I'm like, yeah, man, that sounds fun.
right. No, this is where going back to the self mistrust, because I think a lot of the unpredictability in ADHD is when it comes to, and what you said, the things, the plans, the circumstances most within our control. Now, even within that, there can be unpredictability, a pop quiz in a class, a a sudden change at the office. There's going to be unpredictabilities in there, but generally those are the equally distributed ones. Anybody else walking into the class that day is going to be subjected to the pop quiz. And maybe there are some students who they before every class they study for a possibility of a pop quiz, even though the professor says it's only going to be once a week. Or whatever. I'm making up a scenario, or something at work. Oh, we didn't get the funding, so we're going to have to cut people. That's equally distributed. I think where we're talking about is some of the scenarios that I mentioned there here. Getting together with friends. Now, somebody gives you an invitation last minute. Hey, we're doing this. Do you want to come? Yes, I'm in. And that is what that is making a decision. Now, maybe later on, somebody might say, yeah, I was on the train down to DC. I'm thinking, yeah, I shouldn't have done this because I have all these things or this thing due Monday and I didn't bring my laptop with me. And even though I can find a computer, it's like whatever. There can be the impulsive compliance, which I mean, and I want to make the point when I'm working with somebody, this is not to do away with spontaneity. No, you have to say no to everything. You have to go home, brush your teeth, and get into bed early. Even though getting good sleep is important. No, there is that, but it might be that checkpoint of, tell you what, when do you need to know by? Can you give me 15 minutes? I just have to make sure there's nothing I'm forgetting. These stop gaps a little bit, which these can be forgotten sometimes, or sometimes you go, okay, I'm going to DC. I probably shouldn't have, but I'm going to message my boss to say, something happened. I can I get you the thing I promised you Monday, Tuesday? And this gets back to like the what I call the social capital, the personal influence to say, even in that case, let's just say, I don't want to say it was a mistake, but it was an oversight. You say, I jumped to the DC trip, said yes to it, even though now that's going to tie my hands in terms of work. And this is where the shame comes up. Well, a lot of people would say, okay, I just got to go make the best of it and I'll figure it out when I get back. As opposed to, something came up, I'm going to be unexpectedly out of town. I'm not a big proponent of lying, but I'm going to be unexpectedly out of town, which I guess would be accurate. Is it possible to get an extension on the thing I promised you on Monday? And if the boss says, yeah, that's sure. Yeah, sure, that's fine. Okay, great. But a lot of folks would not reach out of shame and maybe based on the past expectation of this doesn't go well, they're going to say no or whatever. And that might be, you mentioned before, some of the childhood training, the teacher goes, no, the deadline's this, or everybody else handed it in or whatever. But sometimes there's a little more flexibility in college or the workplace where reaching out and asking for an extension, it works out where you go, okay, maybe my decision to go to DC was impulsive, but I used good problem solving and I made it work out anyway. So this goes back to, isn't the life unpredictable? Yeah. And like you said, what one of my clients said early on in the pandemic with the lockdown and everybody was struggling doing work and school and sometimes, four or five people in the same house doing all of them, all in the same router. They said, now people know what every day of my life has been like before the pandemic, trying to set up the day and, things making it more difficult. So, in that way, yeah, that sort of spoke to the unpredictability of life. But going back to, I think what's the unpredictability for folks with ADHD are all the efforts to have things be more predictable. Doesn't have to be, and it doesn't have to be boring predictable. There can be spontaneity in there, and time out with friends, and planning trips, but trying to keep up with other endeavors for which there's buy-in. And that's a defining feature of the executive functions and self-regulation. However you define it to your goals, however you define them to be. And so, keeping up with school, keeping up with work, keeping up with friendships, keeping up with hobbies, including artwork and people who say, yeah, I don't get my easel out and do any painting. I never get around to it. Sometimes it's even the want tos. It's not just the have tos. It's the things like I want to do this, but I never get around because it's a hassle.
Back to kind of one of the questions about the CBT, which is where is it being implemented and is it being widely accepted and used as a form of like if a person goes to a doctor with a ADHD related problem and are they given a more prescripted route or is there being the word CBT thrown out there? I'm still in belief that a lot of people don't really know exactly what CBT is. I think I'm still in that area as well, but I think is it something that doctors are aware of and they're able to be like, hey, there's this method you could try, or is this something someone has to go search out for their own?
It may be out there a little more as a recommendation, but there's still access and finding people who specialize in it because um, I'd say in generally behavioral health care, there's I don't think there's a lot of training in ADHD in general, probably more in like child psychology residencies or internships. There's probably better training of it, but not specifically adult ADHD. I think it's getting a little better at some of the the ADHD programs are around there. And
I went to a behavioral health place and it felt like I was in court. I was really like
yeah,
intimidating to
see,
be in
yeah,
there.
and that's why, some people say going in for psychiatry or even calling up with the stimulant shortage, calling up pharmacies, and some people saying I'm made to feel like an addict because I'm trying to, I need my Adderall prescription. I need my Adderall prescription, and it's not like need like I'm yeah, I forget I'm shaking in my bed or anything, but it's just I'm a safer driver if I take it, and
I've never had to convince someone I have ADHD. I can tell you that much. My whole life has never been that. It's always been the opposite. But when I went there to go try and get a prescription, it was like I was in court and they were really like doubting that I had it. And I was like explaining to them, well, I do like, like before I came here, I was doing 6 hours of cardio. I got to go back to work tonight. And then and I was just explaining a bunch of things. And they're just like, yeah. Did you say you do 6 hours of cardio? I was like, yeah. I was like, is that I know that's not normal, but for me, it's just kind of been a thing I've been doing. And I would just start going. And then next, they're supposed to ask me a question. We talked about JFK for an hour. And I go, okay, so is my session over? I got to go feed my dog. And they're like, we haven't even answered any questions. We just talked about JFK for an hour. And I was like, oh, so no, I wasn't diagnosed with ADHD then. There was still like a
right,
space
right.
between.
No, no, I think there's still, and hopefully the US guidelines for adult ADHD, and there are wonderful international guidelines. The European group, Australian group, there's tons of really good stuff out there already. But these will be the first US guidelines, and hopefully to have them later in the year. And then there's going to be like clinical toolkits for different professionals, like neurology, psychiatry. Like I'm going to be working on this, the psychology, work group. Um, for the clinical toolkits. So hopefully that will help, but I still don't think there's a lot of, there's still not the level that we need. So I think it's getting better. But in terms of the non-medical treatments and what works and what doesn't, and what's in between, that might fill a need, and it's good proof of concept, but we don't have all the data yet. I still think it's lagging behind. And in some of the interview studies and qualitative studies of adults with ADHD and their experiences getting the diagnosis, stories similar to yours. Um, one person they wrote that I showed up on time for my adult ADHD evaluation, and I was told, therefore, I can't have ADHD. Somebody else, who had the predominantly inattentive type said, well, you're not fidgeting. That's not ADHD. This limited, almost cliche, cartoonish view of what ADHD is and how easily it is to point out, well, you're not doing this one behavior. Well, you probably know it, seeing you at the gym or like doing your work, you could have a camera on somebody with ADHD, and in the right context, um, they're a rock star. And you go, how can this person have ADHD? Well, that's that the executive function, self-regulation, the agency that we're talking about, and the self-trust, which is self-regulatory efficacy, is being able to do this relatively consistently over time, keeping up with reasonable amounts of different roles and whatnot. Again, not perfect. We all have that day we go, hey, it's mid-afternoon, I'm mailing it in the rest of the day, I'm tired. But we can generally bounce back, and over time, it's a good pacing, and we're keeping up with everything. But with ADHD, the drops can be really hard and painful and get in the way of work and school and relationships and other things, even despite these bright spots along the way. So that's the maddening thing. So I still think there's a lot of work to do. As a close to a final point, and I'll speak of David Goodman. He's on the APSARD group that's working on reviewing the research for the guidelines, and for which we'll use the clinical toolkits. And he showed it on a slide, and I sort of dope slapped myself knowing the data. But back in 2005, there was a national comorbidity study, a telephone survey looking at getting the prevalence estimates of different diagnoses. I know it's a bit dated, but I'm using it because it all came from the same study. Depression at that time was number one, and I forget the exact number, but I think it probably, we won't don't let facts get in the way of a good example. It was like 6.5% of the U.S. population. At that time, anxiety was about 3.1%. They were numbers 1 and 3, depression and anxiety. You know what number 2 was of the most common psychiatric diagnosis in the US in 2005, based on that study? ADHD, 4.1. So depression, ADHD, anxiety, number one, two, and three. But number two doesn't get, yeah, we're talking what the discussion we're having here. If I was a medical doctor, a family physician, and I said, yeah, I'm pretty good at ear, nose, and throat infections. I'm pretty good at spotting diabetes, but I'm not good at like fill in the blank of picking up cardiac problems. Now I know cardiac's probably more serious, and it's, but it'd be sort of like, well, isn't that what you go to a family doctor for? And don't they get trained in it? Because depression and anxiety, and I mean this respectfully, they're the common cold of general psychology and psychiatry practice. But if 88 adult ADHD is number two, and that'd be sort of like, oh yeah, family medical practitioner. Yeah, we don't do diabetes management. And I get it. There might be specialists in diabetes, but at least getting picked up and getting referred to a specialist and having a specialist to go to. So access and know-how in the population is, the professional population is still an issue, but hopefully the upcoming guidelines and toolkits will help with that.
I'll ask just one last question for you because what you just said kind of resonated. When I went there, the first thing everybody was saying is what they've always done when I went to go seek treatment for ADHD. They just always mentioned depression and they kind of start hitting that first. And I'm like, well, the core factor would be ADHD. If I didn't have all these impulses and overactive, just overthinking on everything, like, well, that sounds more like anxiety. I'm like, hang on. I get most of the population focuses on that, but when you're at an ADHD spot or a place that would recognize ADHD's existence, at least, you would think the awareness factor would have at least brought them into, I guess, looking at that as a treatment factor, not just hitting the main one that most of the population suffers, which is depression. So I'm wondering what your thoughts are on the awareness factor of ADHD and how it's evolved into the clinical world.
You know what? Again, I think for my money and something I'm trying to raise more and more. It goes back to the initial training, and I think it's getting a little better. Like when I was at Penn, we had like advanced graduate students in clinical psychology would do a year-long training, and there's other groups like Duke University has an excellent ADHD program, adult ADHD, UCLA does. I'm sure I'm leaving some people out, so it's getting better, but look at the geographic. I said, okay, we got one in North Carolina. We had one in Philadelphia and one out in the LA area. Okay, in this large country of ours. So I still think um, it's not where it needs to be. And going back to the executive functioning model of ADHD, I find the executive functioning model has made me a better therapist, clinician with my patients without ADHD, helping with depression or anxiety as well. So it's not like it's going to be any sacrifice to add that in. And then as a discussion of the issue with this self-regulation executive functioning model with ADHD is for folks with ADHD, it's developmental. Hence, it makes sense why depression and anxiety might jump on at some point, but it's really driven by ADHD. But very often people describe, yeah, I went through treatment for depression or anxiety, especially women diagnosed with ADHD later on. And it worked okay, but then I hit a ceiling and I was still late or things. I felt better, but I was still struggling with the central issues of, things I selected to do. And we're not what we do or our grades or our salary, but the things that we select to do, including for work or school, they're not nothing because there's something about it that we want to get out of it. So that's where that agency and follow through on our endeavors is so central to who we are.
Dr. Ramsay, I appreciate the time you gave me to talk on my show again. It's always a pleasure being able to learn from you. I like your perspective on ADHD. It's like asking you some of these questions because you have a good take on them. And you give a reasonable approach to it as well, too, when it comes to understanding what people with ADHD actually experience, which is very refreshing. But is there a place where people can find your links?
Oh yeah, I got a website, www.cbt number four ADHD.com. And I have links to podcasts I've done with you, other materials, things like that, and keep me updated on what I'm doing. And it's CBT for ADHD. Not sometimes people hear CBD and they get really excited, but it's not that. So, but that's the best place to reach me.
I'll make sure I link all those links in the description. It's been a pleasure chatting with you, and thanks everybody for listening to this episode of Out of Blank. Stay tuned for next